So hello, I'm Lucienne Lutfy-clayton. I am one of the APDs at Baystate, and we are going to talk airway. So I really love airway. I got really into it after I had a case, just after I finished residency. And in that case, I knew what I needed to do, and I had plans. But at the end, even though my patient was alive and everything had worked out okay, I didn't know how to make that airway better. And so that's where I focused a lot of my own learning in airway, and that's where I'm focusing this talk. Not so much on just knowing what to do next, but what can we do to make our patients safer and to get through the day feeling better all the time. So this is upright, awake, and alive. And if you haven't already gotten into doing a lot of especially upright intubations, I'm going to convert you in this talk. So real quick disclosures, no one pays me to do anything, unfortunately. If you would like to pay me to do some things, go right ahead and I will change my disclosures. My images are all open source or with the consent. Thankfully, I have a lot of very nice patients who, when I go back to them, let me use their images. And finally, I do use videos. And these are videos of real airways where we've taken off any information about the patient and we consider them CQI. This is to make you a better provider. So, real quick objectives, we're going to review a real systematic approach to challenging airways. You're going to have challenging airways and we're going to show you what you're going to do with them. We're going to really discuss some special preparation that you need to do for your upright and for your awake airways and when to use them. And lastly, we're going to do cases, because I don't know about you, but these kind of slides are not where I learn, and definitely it's not where I learn airway. So, the first thing for all of us to just admit openly is that 1 in 4 adverse events in airway take place in the emergency department and in our critical care units. We have the adverse events, and so we have to be prepared for them. We can't just avoid them. And frankly, one of the hardest things about challenging airways is you don't know which one is be challenging, right? Like, is it that orange Lego? I'm not sure. I don't see a lot of other orange, so maybe that's the hard one. What about the blue ones? They're all different sizes. Maybe I don't know how to actually adapt to them. How about the one that's see-through? That see-through one looks like it's going to be easy, but I'm going to tell you, a good portion of the time, you might get in trouble with the ones that look the easiest. So what can we do? So the first is I'm just going to have you anticipate challenges. It's imperfect. You can use lemons, you can use Haven, you can do DPAT. I'm sorry, but you may not be able to pick up on the details ahead of time that are going to tell you what the challenge is. But if you see it, you can adapt. The next is you're going to come up with your plan, all right? You want to pre-decide some of the things that you're going to do, not just in the airway you hope this will be, but in the airway it might become. All of us, when we have our patients and we order that chest x-ray and we know that they have a pen allergy, we think ahead to what we are going to give them if the x-ray comes up positive. And the reason is, a couple hours from now, when we're super busy, we need to not have to think hard about what to do. And it's the same for your airways. You're going to get rid of some of that cognitive load by thinking ahead. And the last is just a quick algorithm. If you didn't think ahead, if you had no idea this was going to happen, you need to know where you're going. The best indicator for a challenge is Gestalt. If Santa Claus walks into your ED and he needs an airway, you're in trouble, right? He's short, he's fat, he has a tiny chin and a huge beard and no neck. It's not the airway you want to do, but we don't get to choose ours. So you have to be ready to do it. In terms of what I want you to come away with most of all from this talk, there's a few things you can do with challenging airways. You're going to prep for your success. It's the preparation that's really going to help you to succeed. And oxygen is the best preparation you can do for your patient, all right? You're going to pre-oxygenate, you're going to apox, and you're going to reoxygenate, and you're going to focus that oxygen is incredibly important for your patient. You also need to know that you can plan for failure. So you want to come up with those plans yourself. And the most key that you need to do for any plan for failure is to change. The really worst thing you can possibly do is the thing that in the moment we all tend toward. You're going to try to do the same thing over and over and over again, and it's going to fail every time. You have to change. You have to change devices. You have to change positioning. You have to change intubators, all right? Be ready to make a change rather than doing the same. If it didn't work last time, it's not going to work this time either. What about equipment? So we all have different equipment where we're going to practice, right? I think there's a few things that if you don't have, you should really work to get. So the first is video laryngoscopes. They're incredibly helpful for airway, and for challenging airways, they will improve your outcomes. So hyperangulated blades are the blades you're seeing at that bottom of the screen. That's the one you think about probably with video. And hyperangulated are good. They're good for lots of airways, but very specific airways. And the ones I like them best for are people that have really tiny chins, all right, and who have a short thyromental distance. Or where you can't move your neck around. That's going to be when the hyperangulated is going to pay off for you. The rest of the time, what I like are standard geometry blades. So the beauty of the standard geometry video blade is you can toggle between a standard geometry direct view and the video view. So you can often rescue an airway in a single attempt. You don't even have to change what you're using. Next up is the bougie. If you haven't developed your bougie skills, you're going to take this bougie out and you are going to start using it. Bougie loves standard geometry video blades, absolutely loves them, right? And bougies are really easy to get through the cords and they're easy to see. So they are going to be of benefit for your patients. So you want to develop those skills. Whenever you're developing a new skill in airway, I want you to use it on someone who doesn't necessarily need it and then continue to develop. You're going to get better at the skill initially on people that don't need it, and then you're going to use it on that patient who's going to be more challenging when you can tell you need the skill. The next up is supraglottic airways. That's going to be one of your backups, right? On that patient that I had just after I finished, I had my supraglottic airway out and lubed and ready to go, and it's the reason my patient was able to be quickly reoxygenated and was okay. You need to have those. If you don't know if your supraglottic airways are able to be intubated through, it's a really important question to answer for yourself. You want supraglottic airways that are second generation and that you can intubate through. And if you're going to intubate through your supraglottic, you're going to use a fibroscope or an endoscope to go through. And I'm going to highly recommend, because they're out there, Storr, CMAC, Glide, all right? Have them, as well as Ambu, and they're disposable. So it's a very low investment for your institution. So if you don't already have some of this equipment, you're going to build it up and you're going to make it a priority. And the priority really is for the safety of your patients. So let's get into the meat of this. If you haven't already gotten into upright intubations, they are phenomenal. All right. The bonus of your upright intubation is that it improves your pre-oxygenation. It improves your apneic oxygenation. It lengthens your safe apneic time, so the amount of time you have for your airway while your patient's sat is still good and your patient is safe. It makes all of the fluids run away from you. Blood, vomit, CHF runs downhill. And that's a good thing for you, because it means your optics, whether it's your standard geo video or your hyperangulated, aren't going to get obscured. It's well worth the time and effort. Now, there's a lot of ways to do an upright intubation in terms of positioning. And the key to realize is that if you've been doing all your intubations flat, you're used to your patient's head being flat on the bed in front of you, and your approach is parallel to the plane of your patient's face. And you're used to that being the same parallel to the ceiling, all right? If you're gonna do an upright intubation, you can use 1,000 blankets if you have them. You can use a commercial wedge if you have one. You can use the whole bed or just the head of the bed. And all of those will work. I tend to use the back of the bed most of the time, but it means that my patient's face isn't parallel to the ceiling. So now my approach is different. I adjust me to the position my patient's in. If you get used to that, it'll be really easy. The next is your positioning, all right? You, most of the time, traditionally, are gonna go right over the head of the bed, all right? The problem is you get into a position that's not always very comfortable or very stable. So one of the things that I discovered one of the times I'm dragging up a chair and a stool, because it's probably unclear to you, they had to change the level of this camera about 3 feet down to get me in screen. Yeah, I'm short. So climbing on the back of the bed on a chair and then on a stool and then leaning over didn't feel great. I never fell on my patients, but it was going to happen one of those days. And as I'm dragging everything up, I realized, you know, when I get up to my patient's shoulders, I actually have a pretty good view. So what I started doing was intubating from the side. And what I mean by that is I am standing at my patient's side. Here's my patient. My patient's feet are in the usual position away from me. I'm at the head, head's right here, and I do a little lean. And it's really easy to do my intubations that way. So if you're short, or if you just don't like falling on people, really consider going from the side. So who's going to benefit? From upright intubation, Santa Claus, definitely, all your challenging airways. Blood, vomit, charcoal that already got given, all right? And any of your patients that are hypoxemic. Right now, one of the things we're all thinking about is what about those COVID patients? Well, they really do well with upright intubation. This is a skill you need to develop because we don't know when the next wave is coming. And when you go to intubate your COVID patient, you definitely want them upright. It's going to improve your pre-ox, your apox, and your safe apneic time. So do these patients upright. Up is good, down is bad. Make this adaptation. It won't be hard, and you're going to learn it initially on patients you don't obviously think need it. How about this apox? I've been saying things about apox quite a bit so far. If you're not already using it, it can be really helpful. The best way to use apneic oxygenation is to use a nasal cannula in your patient's nose, turned up to flush. If you got a COVID patient, might inch that down to just 15 and not put it all the way to flush to make things a little safer for you and your team. One of the biggest mistakes I see made is people leaving capnography nasal cannula on and trying to do their apox through it. The problem with that is, and this might be actually a little hard to see, but I want you to look over here. This is your CO2 sensor. This is going up, telling you what the CO2 is. And if you follow that, it comes over to here to this side, to the prongs, and then to the flange. All of that CO2 sensors. You know where your oxygen's going? It's going up this side to these cute little holes in front of the nose. You're giving blow-by, and that's why it's not working or helping your patients. It's also why if you turn it up high enough, the whole capno just comes rushing off their face. So stop doing that. When we looked at our shop, when we don't use apox, our first pass success is 81%. That's just a little tweak below national average. When we use apox, it's 88. A nasal cannula just staying on the face, getting you 7% better first pass success is well worth it. What about awake? So again, you want to select these patients. Challenging, absolutely. Hypoxemic, absolutely, because they're going to keep breathing. Distortion. When your patient has distortions, this can really help them, all right? When your patient unfortunately has hung themselves and may have a laryngeal fracture, that's a big distortion and it's one to look out for. Patients that have burns, you may want to consider doing an awake intubation. And the ones that I think benefit the most are your profoundly acidotics. DKA, aspirin overdose, you should be doing them awake. You will save lives by doing that. What about coronavirus? No, all right? You don't want your COVID patient to be stimulated and cough on you. So you're not going to do any of those patients awake. Awake intubations can be a little bit of a trap, all right? They can be really good for the right select patients, but if you use it too often, you're going to run into trouble, all right? When a study was done to look at 456 patients that were intubated with some challenging markers at an academic emergency department, they found that their first pass success in challenging patients with RSI or DSI was 90%. It's really good first pass success. With awake, it was 57. You're losing quite a bit of your first pass. You may not get it on your first pass when you do awake. So you want to select those patients carefully rather than increasing the adverse events by doing it on everyone. So why would I even encourage awakes? It's going to reduce your can't ventilate if you select the right patients. It's going to improve your oxygenation because they're going to keep breathing. And it's going to limit that apneic time, especially in your acidotic patient. It does risk your first pass success and it risks adverse events. So remember to select your patients carefully. And that's why we're going to go over the cases so we can touch on who's really benefiting and who's not. So our first case is a 46-year-old female. She presented somnolent, febrile, and hypotensive. And you're noticing right from her image that unfortunately she has some markers for challenge. She has a tiny chin. She has a short neck. She's obese. And it's not apparent from the image, but she has severe rheumatoid arthritis. So you also can't move her neck. All of that should lead you to saying, I would like a hyperangulated video blade to intubate this patient, right? So that's what we did. We did an upright intubation with a hyperangulated VL. Our backup plan was standard GOVL in case the anatomy for her just didn't work with our blade. And then having our SGA prepped and ready. And because she was hypotensive, we used push pressors as a pre-medication. Put your pressors in so you reduce the time that it's going to take for your paralytic to be effective back to what you expect. So here's her actual airway. So yeah, suction. Suction would have been lovely if it had happened before this. But here we are, we have a view. You see a lovely epiglottis. You see your posterior retinoids. You're a little bit too close. All right, you want your glottis to be less than 50% of the screen, and you see they're having trouble actually delivering the tube, and that's what's going to happen with your hyperangulated, especially if you get too close. So what you're going to see is they're actually going to back up a little bit, all right, and this is the advice that you can give to your learners and you can take as a learner. Have the cords less than 50% of the screen. Makes a huge difference. You can see they're able to then deliver the tube with just a little right turn off their stylet right as they're getting past the cords. All right, so it's a nice airway. Let's talk meds a little bit. We love Etomidate. Most everyone in emergency medicine in the United States thinks Etomidate is just the greatest thing. I mean, there are butterflies and tweets. It's just gorgeous. The problem is Etomidate actually has some real negatives to it. And we should be aware of them so that we can actually make good decisions. And the first one is that even though it's usually hemodynamically stable, in your patient who is obtunded or hypotensive, it may not be. And it can cause peri-intubation hypotension and even a peri-intubation arrest if you don't lower your dose by 50%. The next thing for Etomidate is sometimes people are using it when they want their patient to keep breathing. So that DSI, when you separate your induction agent from your paralytic in order to accomplish a task, well, you want your patient to breathe while you accomplish that task. And Etomidate's not going to keep your patient breathing. If you want to take a look, if that's the task you're trying to accomplish and make sure you can see your view, Etomidate's not what you want because they will have stopped breathing at this point and they have no protective airway reflexes. So that's not when you use Etomidate. And the last piece, we got to address adrenal suppression. There will be adrenal suppression. It'll be 48 to 72 hours, and we have no idea what the clinical significance is, but it doesn't increase length of stay in an ICU setting, and it doesn't cause increased mortality. So Etomidate, maybe have a trial separation. We have some better meds. Reduce your dose by 50%, and this is not what you use for DSI or awake. Take that off the table. How about Special K? Oh, Special K is awesome. Ketamine is a great drug, and it's great for our airways, all right? It's going to retain the protective airway reflexes so your patient keeps breathing, all right, and everything doesn't collapse together. So when you want to do DSI or you want to do awake, special K is what I reach for. The other thing is that it does actually, for most of your patients, going to increase their blood pressure. It's also going to increase your cardiac output, so it's going to be one more thing that helps your paralytic actually be effective in the time frame you expect. Go right ahead and use it, but in your catecholamine depleted patient, even ketamine can reduce your blood pressure if you don't cut the dose. So still cut it by 50%. It is safe. Go ahead and use it for DSI and awake, and cut the dose in hypotension. If you're not already using them, have your pharmacy make up some push dose epi for you. Use it before induction to increase your cardiac output and to make your airways safer. Next, we have a 58-year-old alcoholic who has a upper GI bleed, he's hypotensive, and he's somnolent. None of that's good. So we're going to do an upright intubation. We're going to use salad for our suction, all right? That's where you're going to decontaminate your airway ahead of your view the whole time. You're going to use some push pressors, and don't forget the blood's the product that you need. So here we go with the airway. You noticed your uvula. They do have suction, and you're seeing your suction. Would have liked it slightly earlier, but it's still good suctioning at each level. And then, it's rebuilding. And that's because they forgot the last step of salad, which is after you suction at every level, you're going to bury the suction over to your left-hand side so that it keeps suctioning just like when you're at the dentist. And that's going to keep that blood from rushing back up at you. They have a good view. They get their tube in. They do need to do a bit of a right turn off their stylet, but a beautiful airway. So salad, super easy and really, really going to help you. So another skill to be developing and using on all your airways. You're going to lever open the mouth with your suction. You're going to lead with your suction ahead of your laryngoscope. You're going to suction at every level. And when I say every level, I'm speaking of each of the levels in that progression you're going to do on each of your airways. You're going to suction at the mouth. You're going to suction at the uvula, you're going to suction at the epiglottis, and you're going to suction at the level of the cords. And then you're burying it to the left. You can either lift over your laryngoscope, or you can move your laryngoscope forward and go behind. So for GI bleeds, it's a great moment to use your upright positioning. You don't want blood rushing at you. You want it to rush away from you. You can use an NG in order to actually try to get that blood out of the stomach. I have to say a good portion of the time, I just don't have time to do it before my airway. And so I don't spend my time on that. I spend it on my pre-oxygenation and my positioning. And don't forget, if they're hypotensive, you got to cut that dose. How about trauma? Can we do upright intubations in a trauma patient? And we can, all right? You're gonna tilt the whole bed. So this is a trauma intubation. He's 46 years old. He's intoxicated. He fell. He has a head injury. His GCS is 7. He has lots of facial injuries. It doesn't look good. We did apneic oxygenation. We put him in reverse Trendelenburg, all right, so that his head is above his feet, but he's still with a C-spine immobilization. And obviously with the blood, you're gonna wanna use that salad technique and have your adjuncts out. So attempt 1, they used a Mach 3. They didn't hit record. Attempt 2, they used a Mach 4. They didn't hit record. Unfortunately, couldn't accomplish it. Attempt 3, they hit record. So you can see now why they're having some trouble. They're doing apneic oxygenation. They're coming in, all right? You're gonna notice that they come right by that first stage, that uvula, and they are gonna suction. What a nice job. Now they're coming forward, all right? They didn't do a lot more suctioning, and you're gonna see that their view is pretty imperfect. It is less than 50% of the screen, but we would like the whole glottis to be there, not just the bottom. Still, it's enough. But when you have a restricted view, I'm gonna encourage you for bougie. You're gonna see that they go low and to the right. So what they need to do is come back, lift up to the ceiling, and go forward. It changes your geometry, and it's the way to get out of that positioning where you're going low. I call it a hands up. You move your hand backward and up, and then you go forward again, all right? So try that the next time you're having trouble and you're low. So it went beautifully. It took some time. This took 8 minutes from arrival until the tube. They went through 2 operators, and that's appropriate. They communicated the whole time, and the lowest SAT this patient had, I think in good part because they were upright and they did both pre-ox and apox, was 98%. That patient went through 3 attempts and did great, and that's why we do this. Our next patient is a 38-year-old. He awoke with smoke detectors going off in his house, and unfortunately, he ended up having really significant burns because he was protecting his child in front of him while he desperately tried to get the door open. He had 2nd-degree and 3rd-degree burns over his back, his head, and his hands. He had carbonaceous material in his nares and in his pharynx. But the good news is his SAT was 100%, he had no stridor, and he had no voice change or trouble breathing. This is one of those times where you have to make a decision. Do we go awake with him, which is probably the safest, but I might need to do multiple attempts, and I'm gonna actually cause some trauma and some swelling to this airway that already might have a little swelling? Or do we go with an RSI or a DSI, maybe a little riskier because he's gonna stop breathing, but I don't think I'm gonna cause as much trouble, and I hope that I'll be able to get through. Since he didn't have stridor, he didn't have a voice change, and he wasn't having trouble breathing, I decided to go with an RSI. We kept him upright. I used a standard Geo video blade. I had my bougie out. I had already pre-decided that I'd size down my tube just to try to get myself better first pass success. And I like to do my stylet straight to the cuff, and then I angle off at the same angle that you'd expect a bougie to be, all right? It's 37 degrees, but you can just eyeball it, but that's where you put your angle, way at the end, not curved, so you get your view the whole time. I had my SGA out and lubed, and I had the neck prepped. And this is an airway I did rather than having one of my learners do it. And the reasoning was that my learner was one of my physician's assistants, an amazing physician assistant. That's not probably the right person to do this airway. You want your most experienced intubator, and you have to make that decision in the moment. So here's this airway. So as we come in, you're gonna notice we're seeing molars. You probably shouldn't be seeing those. You're gonna sight your uvula, and then you see your epiglottis. And the one problem here is I'm way off to the side, and I don't have good tongue control because of the positioning I'm taking. So I come back at a reattempt, and now you have a much better view. All right, still ordered approach. You see your epiglottis, your posterior retinoids. They're a little swollen, but you have a good view. Tube comes down, easy delivery, right turn off the stylet. So for burns, upright's great. You do need to consider awake in DSI, and that's gonna be a judgment call. Make sure you do that double prep, all your adjuncts out, best operator, and I like the standard GOVL so that if my optics get obscured, I know I can toggle back and forth. One of the big questions with awake versus non-awake intubations is to sleep or not to sleep. And here's my bottom line. If there's fluids or your patient's unstable, don't do your intubation awake. If your patient has acidosis, do it awake, severe acidosis. If your patient has a stable distortion, they had surgery on their trachea in the past, you see a distortion, they have a mass, you're doing that airway awake. If they have stridor, you're doing that airway awake, right? That's my big lines, and that's what I want you to take home. And I think that's where you're gonna get your awake intubations to benefit your patients most. So our first patient's a 55-year-old obese male. He has hypercapnic respiratory failure and a history of CHF. He wasn't floridly in CHF, so I still think the awake was an okay plan. He is hypoxemic. He has a tiny chin and a short back neck, right? To illustrate this, you can see him right here. And yeah, he's gonna be a challenging airway. We did our pre-ox, we're doing apox, and as we go in for this airway, you're gonna see his uvula beautifully, nice ordered approach. All right, we get over the uvula and we're seeing epiglottis again. There's a reason we're not suctioning right now, and that's that we're gonna use some 4% Lido. I really like to put some 4% Lido in at the glottis to reduce the amount my patient is going to cough at me. We did use ketamine. I'm a big fan of ketamine for my awakes. You see them coming with the tube and they're going a little low, all right? You can see posterior retinoids and your epiglottis. Patient's gonna take a breath and you'll see the cords open up in a few seconds, and they're just low. And they could have tried to do a hands up, all right? Tube back, and they almost got it. They get right about to the glottis and they sort of lose it, right? Decision was made. We are able to accomplish the view. We know this patient is in a hypercapic respiratory distress, but it's okay now because I know I can get my view to briefly use a paramedic. You have two choices, all right? Now we suction beautifully. They come in and you're gonna see that they're able to get the airway pretty smoothly now that the patient's no longer breathing. There's a couple things you're gonna do to make this more safe if you give the paralytic. So the first is either use suck, so it's short acting, or use rock and have your Sigamidex out, already dosed and given directly after you accomplish the airway. So your patient starts breathing as soon as possible. And next is already set your vent. So your patient goes directly on your vent and you've already got it set up for them, right? Those are the things that if you're gonna use a paralytic in one of these patients, it's gonna make it safer for them. So our next patient's a 45-year-old diabetic male presenting with altered mental status. He's hypoxemic. His family says he's had nausea, vomiting, and diarrhea for 4 days, and he's confused with abdominal pain. And so we all immediately like, oh, DKA. I don't want to intubate DKA. But this gentleman is truly obtunded. You have to intubate him, and you don't yet know what his pH is. So you got to assume it's bad. You do it awake. He was done awake, upright, with apneic oxygenation. You're seeing beautiful uvula and then epiglottis, all right? You see your posterior retinoids. You see that your cords are moving. I love bougies for these. We did use an ET tube. You can see that it briefly went low and to the right. They did a hands up. They're able to get right to the glottis. And now they're gonna advance off the stylet with a right turn in order to not get hung up on the anterior trachea. So it's a beautiful airway. It went smoothly. Patient did great. pH was 6.9 is what we discovered post-intubation. So I'm really glad that patient kept breathing. Other things that can help your DSI in your awakes, you can dry your patients up. Glycopyrrolate or atropine. Trouble is, it's gonna take 10 to 15 minutes once you actually give it to your patient. So not very often that it's practical. Salad's gonna help you out. Please use it, but not when you're giving your 4%. I love bougies for these. This is one of the reasons to develop your bougie skills so that you can keep doing it. And it is okay to use a paralytic if you have a plan for how that paralytic is, one, gonna be shortest acting as possible, and that you have your vent already set up so you immediately have your patient actually breathing again at an adequate rate. For your awakes, use 4%, ketamine, no Etomidate, bougie. What about post-intubation management? I'm sorry, I'm an airway person. I'm gonna talk about it every time. So there's some really simple things that I want you to keep in mind, and it's true for all of your airways. You need to be using some sedative and analgesia. I personally use my analgesia first. Next is you need to ask yourself 3 questions, and just 3 questions. Is my patient acidotic? Okay, great, high rate. Is my patient have some obstructive lung disease? Great, low rate. Do I care about my patient's lungs? I hope that you do. And if so, you're gonna do a low volume, all right? Use ARDSnet, put the cards right on your vents so that it's easy for you to do appropriate volumes for all your patients. And keep them upright. Not only does it help with recruitment and reduce de-recruitment, it also is going to reduce your ventilatory associated pneumonia. So even though you don't think these hours are maybe as important, there's some good studies that show that even the hours in the ED are really important, that we both use appropriate settings and that we keep our patients upright. So we've covered a lot of material. The biggest thing I want for you in terms of your take-homes is to remember that the ED is an area where we have a lot of unfortunate adverse events, but we can reduce them. You're going to prep for success and you're going to plan for failure. You're going to use oxygen. You're going to change. Don't do the same thing over and over again. If nothing else comes from this, up is good, down is bad. And salad, super easy to learn, and it will change your life in terms of your suctioning. Thank you so much.
Dr. Lutfy, that was a fantastic talk on airway, and we really appreciate you giving it. Would you mind answering just, like one kind of big question that I know anybody watching an airway talk is thinking about?
Yeah, anything.
Our COVID patients start oftentimes, especially the ones we know we need to take the airway, they start really hypoxic, and we're really discouraged from doing the usual things we do to reoxygenate them. Do you have any particular things that you found helpful or useful in intubating those COVID patients?
Yeah, so I think there's a few things, and I know that we're all scared, and that's reasonable. We need to protect ourselves and the families we go home to. But we also have to protect our patient, and that can be a hard balance. But I think the balance that you need to strike with your COVID patients who you're going to intubate is, one, you gotta have them in an upright position. It will improve their recruitment, and de-recruitment is a problem in COVID patients, so please have them upright. You do need to pre-oxygenate, and you can still do that safely. You have a couple different options for pre-oxygenation. The first is a nasal cannula and a non-rebreather, right? That is safe and it's appropriate to do, and it's going to reduce how much aerosols you have. That would be for your patient who you are concerned may have COVID, but isn't particularly hypoxic right now. If your patient's particularly hypoxic, what I want you to do is put a nasal cannula on that you'll continue throughout the airway for apneic oxygenation, and then you're going to put a BVM on your patient with a PEEP valve. You're going to do a good mask seal, and if you haven't gotten into the habit, stop doing EC. EC is hard, and that's not just because I have tiny hands. EC is hard, we don't get as good mask seals. But using your thenar eminences on the sides of the mask and then lifting your patient's jaw into the mask actually gets a better seal. So get a good seal with your nasal cannula under your BVM and your PEEP valve on, and now you're giving positive pressure. I prefer that to bringing in whole different equipment because obviously we have a lot of decontamination that we have to do. You should be in a room, ideally that has negative pressure, but even if it doesn't, have a closed door, bring only the equipment you need for that airway in, and then you need to have a runner in PPE who's gonna hand you the equipment you need as your backup. So you have them all set up right outside the door so that someone can hand it in if you need it, all right? That's the things that are going to keep your patient. If you do not achieve first pass success, your patient unfortunately becomes hypoxemic, less than 92%, you're going to need to reoxygenate. Throw a supraglottic airway in. I don't have any data behind this, but I truly believe it. You will get a better seal, and you will have one person that's able to reoxygenate your patient instead of multiple people touching them, and that's going to bring greater safety to your team.
And just one quick follow-up. What about those plexiglass airway boxes that are making their rounds all over the interrooms?
So, I think during this pandemic, we have had so many wonderful ideas, but some of them don't pan out. And this is one of the ones that just doesn't pan out. We actually did test these out. The anesthesia department had a few built and very graciously let our emergency providers try them. And the fact is that if you try to do an upright intubation in one of these boxes, it is extremely difficult. You have trouble actually reaching and doing what you need to do. And I believe that you're going to actually delay the intubation, your attempt's going to take longer, and there's a much higher likelihood that your patient's actually unfortunately going to become more hypoxemic, and you're going to have to do additional attempts, which isn't good for you or your team or the patient. So please don't use the plexiglass boxes. If you're going to use them because you really believe it's going to be good, you got to sim them. You try it over and over and over again before you use it on a patient.
Dr. Lutfy, thank you so very much.
You're very welcome.